Okay, so I'll start now, and obviously we'll go through the introductions, and then that'll give people some more chance to join us as well. So my name's Mark, and welcome everyone, and thank you for joining us today on this webinar, um, arranged and supported by the Advanced Services Group. Just to set the scene for the day before I introduce our guests today, I know we often say that the NHS continues to face one of the greatest challenges, maintaining high quality outcomes in a safe and with a timely patient care way, and all of that whilst trying to manage the financial constraints that are put upon them. And as these demands rise, the pressures that are created on the workforce and the expectation for those improved outcomes increases, it puts more pressure on the healthcare leaders to try and provide all these great services, but also balance the financial books, and potentially recover some of the financial losses that happens with the NHS currently. And all of this whilst doing trying to provide a long-term sustainable service. So there's a lot of things to consider. Now, I'd like to say we've got all the answers today. We haven't, and if I did, I'd be a millionaire by now. But we haven't. And what we're going to do today is just to explore a critical question, which is what the question we've got here, which is, how does the NHS sustain service delivery while meeting short-term financial targets? Now, unfortunately, one of our speakers, Phil, is unable to join us today at short notice, and this probably also suggests one of the issues that we've got in terms of with the NHS, in terms of actually having enough people to manage and to look after everything that's going on. And unfortunately, he's unable to attend with us. So we've had to make some last minute changes to the webinar. However, we still have a fantastic speaker, Darren, with us, who will be looking to provide us with some insights from both a procurement and a finance perspective around DHive and what DHive does. And I'll explain a bit more about Darren in a minute. But for now, if we can just move on to the agenda, please. So the agenda, I'm going to give a small sort of introduction into the Green Healthcare Hub project that is ongoing, and the relationship between Advanced Services Group, Aston University, and the Hub. And then Darren's going to come on to what it really takes financially, and I'm looking forward to hearing that. Then originally it was going to be Phil, but I'm going to instead just talk briefly about the value-based procurement guidance that was issued, and give a medtech company perspective of what that will mean to us as providers to the NHS. And then we'll have some question and answers. And if you have any questions, feel free to put them into the chat, ready for later on. And then we'll finally end up at finishing at 1 o'clock. So that's the plan for today, for this next hour. So just to give you an understanding of the Advanced Services Group, who we are, what we do, and the relationship with the NHS as we have it here. So the Advanced Services Group, it's a group created out of Aston University and led by Professor Tim Baines, a leading authority in service delivery. And that group ultimately uses research to understand the benefits of service, and using that research to support and help organisations deliver better and improved service, and understanding the different levels of service that are available to to companies. So ASG has helped over 500 companies, and it supports the leadership team within those companies to take them on that full servitization journey. And the leadership is really important, as I'll come on to in a minute. But ultimately, it's based on research. And as you'll see in the next couple of slides, it's the research that actually provides the data to show the benefits that service can offer organizations. So if we can move on to the next slide, please. We got the next slide. Gang. Next slide. Yes, we seem to have a technical issue. Here we go. But one of the studies that came out last year was called Design, Make and Serve, the big business case for servitization. And this was a huge study that looked at organizations and companies who either didn't or do offer service, and looking at what ultimately drives the success of service. And I mentioned it briefly on here, but on the previous slide, but organizational leadership is really crucial in delivering service. And whether it's the NHS or whether it's organizations, medtech companies, whether it's any of those aspects, leadership is really important. And those that have strong leadership that is passionate about service has a 9 to 14% higher productivity rate, which is fantastic. Equally, customers are important, and those organizations that prioritize the customer relationship, and that's what services is driving, is better customer relationship and they will achieve service success of around 11 to 13% higher productivity. So there are some really great messages around what service can offer you and offer the NHS ultimately. And this is driven by data. If we can move on to the next slide. Now, to correlate with that, when we look at sustainability, within that topic, do services provided by your organization create an environmental performance gain? And as you can see, yes, it does. Those companies that were surveyed, there is a definite benefit environmentally for those companies that offer service. And then who is the biggest beneficiary of that environmental performance? Then obviously it's the customer and the company. And when we look at the NHS and medtech companies and the drive towards sustainability, these are obviously key figures that demonstrate that service is a sustainable process that can deliver improvements. So if we move on to the next slide, please. So what's the connection between Advanced Services Group and the NHS? Well, the Aston University is part of a much bigger project, which is called Decarbonising the NHS. And this is a National Institute of Health Research funded project. It's the first huge project looking at decarbonising the NHS. And there's a huge amount of investment there, as you can see. And within that research, there are 7 disciplines, 7 hubs that are looking at various aspects of it. And the aspect that Aston University and ASG are looking into, and the theme is increasing sustainability and reducing cost through service delivery. And that's key why we're here, looking at what can service do to support the NHS in delivering reduced carbon footprints and also reduced costs as well. So that gives you some idea of what we're about and why ASG are involved in this. So if we can move on to the next slide. So today's speakers, obviously, unfortunately, Phil's not here, as I've mentioned before, but I'd like to welcome Darren. Thank you very much for joining us. Darren is the managing director of DHive, who is a wholly owned subsidiary of the University of Hospital of Derby, and part of his remit. I don't want to steal his thunder, but he covers a lot of aspects of procurement and finance, including things like managed equipment services, and that's one of the key areas that we'll be talking about now, and how service benefits the hospital through DHive. So, without further ado, I'm going to pass over to Darren. Oh, sorry, no, I'm not. I'm just going to have a quick poll as well before we pass over to Darren. So, you should come in a minute, George. You'll see a window come up on your screens, and we're just going to have a quick poll here as to what's the biggest challenge in equipment management today. If you could tick on that, this is for our benefit to understand what the challenges are and what's more important. Is it downtime, cost pressure, contract complexity, procurement restrictions? And we will use this data as part of our research with Advanced Services Group and Aston University to formulate more data to support the service provision and the service study that we're looking into. So if you could all just click on that momentarily, and then once we've completed that, then we can move on. I'll give you a minute. Okay. Have you all made your choices?
Okay, I'm going to end the poll now. If anyone wants to quickly put their last vote in, I'm ending the poll.
Great. Very good. So as you can see there, downtime is the lowest, which is an interesting, but cost pressure, as we would expect, and contract complexity. That's an interesting one, Darren. Contract complexity. I don't know whether you come across that, but anyway, we can talk about that later. And procurement restrictions, and obviously procurement restrictions might lend itself well with the value-based procurement. Whether it is a restriction, it's going to cause restrictions, or whether it's going to open up the opportunities more. Let's wait and see on that one, and we'll discuss that later on. So thank you very much for the feedback there on the poll. So I'd like to pass over to Darren, please, and we're looking forward to hearing you talk about DHive and how that impacts the procurement and the finance in these financially constrained days.
Yeah, thanks, Mark. I'm not going to talk too much about DHive, if I'm being honest. I don't want it to sound like an advert. I'm really pleased to have been offered the opportunity to come and talk here today about how the commercial offerings within the NHS really matter. Just my background, as Mark's already said, I look after a subsidiary of a relatively large NHS trust. But by trade, I'm an accountant, and I came up through the trust looking after procurement, hence the link here. But as a provider of services, I do have a somewhat dual view of some of these issues now. To start with, I've broken this down into almost 3 time periods, and it's the obvious past, current, present type situation. And so if we look at where the NHS was, it's historically, as it says there, it's historically been a very traditional capital revenue type setup. We all know about the capital impacts that have historically impacted the NHS, and those rules have been tighter got tighter in the 11 years that I've been with UHDB. Historically, when I first joined the trust, it would be a relative source of frustration for me that we would look at initial cost, and no one ever really considered what I'd call a TCO, and that's probably a phrase that you guys aware of in terms of the total cost of ownership or use of a particular asset. And capital and revenue was often split, with revenue being a tomorrow problem and capital being a today problem. The final point there, I think, is the really important one. So there was never, in my experience, an acknowledgement of what we really needed and what we were trying to achieve, and it was what's the best we can get for the budget we have available. So there was never a concept of we don't need all this capital. We would find a way to spend it, and that's quite a traditional NHS approach. That moves us on to where I feel we got to, and this is close to being the current, and was driven by the capital becoming tighter. So really, there was a lot of clever people in the NHS effectively paid to find ways around some of these accounting regulations, and alternative structures were put in place. So we will all be aware of some of the MES structures that are now around, or the managed equipment service structures that are now around. I'm going to give some examples as I go through, just from my experience with UHDB. I don't want anyone to feel like I'm endorsing anyone in particular. These are just particular examples that we deal with. So in our example, we have a large managed service contract for imaging equipment with a company called Agir. And essentially that's an alternative structure that originally avoided our CDEL impact, as we refer to it, the capital that sits on the balance sheet and reported into the NHS centrally. It was VAT efficient in the sense that under the contracted out service headings the NHS use, we were able to reclaim VAT on service impacts that the capital was rolled up into. Now, that didn't necessarily make it less cost effective, and I'm going to come on to that. But what it did do was lower the amount of capital that we spent by virtue of the fact that you're no longer including the VAT, and it's avoiding your balance sheet in the same way, so that the capital we were left with was able to go and be spent elsewhere. So that the focus was always on how do we get more equipment for the money. And I often joked within UHDB that there's certain people around, if you told them there was 100 quid left, they'd go and buy a toaster. So there's very definitely a mindset approach to this as well. These large contracts would become very complex, and I'm not in any way surprised to see people taking contract complexity as one of the key issues. I'm also not surprised to see downtime as a low priority, largely because the manufacturers have worked really hard over the years, and the kit just doesn't suffer downtime really anymore if it's, you maintain it in line with the schedules. So those were two that were right in line with what I was expecting. But these business cases would then use what I would refer to as theoretical costs, and they were built backwards. So you have the desired outcome in mind, and that would then be supported by vague benefits. The VAT was a large part of that. There was green book rules being followed that would manufacture an answer. We'd talk about saved clinical engineering time because the equipment was going to be managed by a third party. What we never did was say, well, who in clinical engineering do we not need to employ anymore? And that's key to this story, really, because in some respects, when companies like Agir are talking about procurement benefits and the fact that they're going to go and do procurement with the likes of Philips or GE, Siemens, etc., you don't need so many procurement people. The truth is, when you're spending that kind of money, you're just spending it with a different person or a different entity, and therefore your procurement doesn't go away; it just changes. And so it's really important that when you start to assess these business cases, you start to assess what's the real cash releasing business case element and what's the theoretical element. And you will, for those people within the NHS, you will have all seen a business case where 3 minutes of nursing time per patient is saved, but ultimately they're just redeployed into gaps that theoretically exist. So this middle structure became what we call a service in the current world. But what it really does is in my view, repackage a purchase, and I'm going to come back to that shortly. If we move on to the future, as I've referred to as, and I'm hoping this is closer than we'd think. This is where we shift from ownership to outcomes, a true service approach. And the closest example I've really got here is the way aircraft or airlines buy aircraft engines now. They don't ever really own their engines anymore. In fact, they don't really own their aircraft to some degree, but they're buying an output, miles or time. And they've managed to find models where people like Rolls-Royce have engineered a much lower cost base by proactively seeing problems, and airlines have managed to release that cost base. And that's the key difference to where the NHS, I feel, is. We want to get to that point, but there's a reluctance to release some of the cost base that funds it. But essentially, what a true service approach is almost per outcome. So we never really own the equipment. I know we're talking about some large equipment here, so some of this is theoretical, but in theory, the equipment could be switched in and out, and as long as it delivers the same outcome, then that's a service. And then there's a fee or a cost per measurable. So in the case of an MRI, a scan, or something like that. The only example I've got within the NHS at the moment to demonstrate this is where the NHS have used private facilities to perform some of the waitlist work. So if you take orthopedics, for example, where the tariff is around £7,000 for a hip or a knee, going out to a third-party private provider of healthcare who would normally be providing either insured work or self-paid work, and the NHS paying them to deliver work is effectively a really good example of servicisation, really. Someone gets paid a fixed fee to do a particular piece of work, and how they do it is on them in terms of the resource they use and what they pay for that resource. So what this model would give us is, as I've said there, stronger account management rather than purchasing. We would move from NHS teams being just purchasing, which is where they currently, we call them procurement teams, but in reality, the very clinical-led procurement means that the procurement team is really just a team of buyers. So we'd move to a much more account management with providers providing outputs, which would rely on improved forecasting and us identifying need up front, something the NHS has been poor at in the past. In theory, and all of this is in theory to a large degree, that would give you fixed forecastable costs for the future. It would allow your executives to plan a lot better, and it would give you a model that scales up and down with volume. And that last point is largely where these models fall down. Expectation is the next phase to this, and this is where it becomes a little bit difficult. So obviously your CFO really likes this model: fixed, forecastable costs, scale approach up and down, linked with income effectively, and the executive wider have the same views with perhaps a more clinical approach and an output-based approach or a patient improvement approach. All of these things are benefits here: lower acquisition costs because you're going directly to manufacturer OEMs, improved ongoing costs associated with life, patient throughput, additional revenues under the old PBR type approach, and in theory, access to newer technology with continuing improvement. We know a lot of these large pieces of equipment have lives way beyond. Physical lives way beyond their technological life. And one of the biggest issues we see is new technology coming to the market that we struggle to access because of an affordability point of view from not having fully depreciated the older equipment. and obviously a true service approach where equipment isn't owned and rolled in and out is a really attractive proposition to the executive teams running the services. If we can move on to the user and clinical expectation side of it, this is where it gets a little bit more difficult. So this is the group of people who are actually going to be involved in the projects that install these bits of equipment. And I've heard all these phrases that I'm going to talk about. So a lot of the time they don't really care about the model under it. What they're really after is the new equipment that they really want to provide better patient outcomes, which is absolutely, please don't anyone think I don't think that's a good thing, but essentially there's no thought of anything around how that happens from a project estate's point of view or what the impact on the finance is. So what they really want is some way to access new equipment, and as the managed service model moved in, the current situation as I've referred to it, they saw that as a way to get new equipment because it was a way of getting around capital. What they really wanted was the managed service provider to go away once it was in, because they wanted to own and treat the kit like it was theirs, because they're looking for the old model operationally with a new model that allows them to get equipment. And again, that level of thinking, as you can see there, shorter life cycles, which gives higher costs and increased costs throughout the lifetime. We do get the increased patient throughput, which is the objective in terms of associated with the new technology and better quality. If we can look, so the third group of people, the suppliers themselves, and this is again another area where expectations aren't fully aligned. So a lot of time, manufacturers will see this as an opportunity to improve margin, and I've seen this in UHDB as well. So the best example I can give externally of the NHS here is how IT has moved from a very box shifting approach to an annuity revenue approach. So we'll have all complained about, our Windows or Microsoft Office going out of date or becoming unsupported, and you've got to upgrade. I was previously at a supplier of infrastructure as a service, where we were introducing this because we wanted to control the life cycles of equipment rather than letting customers sweat their assets for as long as they would actually last. And you can see how all this becomes a zero-sum game around tying the NHS into long-term agreements that force us onto new equipment based on their assumed life cycles of equipment. They get to control market share for longer and, in essence, close off to new competitors. And that last point, I think, links to the access to new technologies. We know that obviously accessing NHS frameworks to sell into the NHS is difficult, but doable. But it's also cyclical. So you can be tied out of a market, blocked out of a framework market for a number of years, which leaves technology either stagnant or in the hands of those that are already on the frameworks, refreshing their equipment. So there's sort of 3 slides there that talk about the 3 different groups of people involved, the categories of people involved, and how if you don't get this exactly right, that slight deviation from expectation makes going to a true service model really, really difficult. So what this really means in practice, I was scared that I'd sent a blank slide for a second there. End users in the past, what they really want is the equipment to control like it's owned, and they go along with the more modern commercial models simply to get access to it. But once it's in, and again, I've heard some of our teams say, why can't a GA just go away once the kit's installed? Executives and CFOs in particular in the future, they've got this story that they've been told, and it works. The biggest issue being that they're not really involved in the day-to-day, and so while they've got this futuristic idea of how their service can look like, they're heavily reliant on end users to deliver that. And you will often hear the joke that there's a random band 7 that can stop any project in the NHS, and it's largely true. So without changing that mindset further down the organisation, this just becomes a theoretical future that we would like to get to. And then the medtech providers are in the current, and that's fair enough, because they're building the service that their users are wanting. So in reality, when you go and talk to the clinical teams about equipment that they want, they want to understand the value, because that's how they get it through their business case process. But ultimately, they just want access to the new equipment, and therefore there's no point in a provider building a really complex futuristic model to suit the executive team, when all of their conversations, all their planning is going to be with the end users. And so there's an onus on the NHS to change the mindset of the people within it in order to take advantage of these new approaches. If we can just move on. So these are all just my views. So in terms of where does that mean the real discussion is? Well, I've just kind of described that executives are already there, but in reality they're not. They're there in theory, and what that means is they need to find a way of putting a strategy in place that gets alignment on the expectation. And it isn't as direct as explaining the future model. It is more the soft skills of changing the mindset, judging risk differently, putting structures in place that mean end users of equipment will look at things differently. We'll look at risk differently. We'll look at problems with an appropriate level of risk, rather than just a blanket level of risk that there's a patient at the end. And that's one of the drawbacks of the NHS systems, I think. So it's a complex problem for the executives to solve, even though that in their own mind they're probably in the future state, and certainly the conversations I have with ours, they're talking about these kind of concepts. So how do you move users effectively 2 generations forward? If I'm considering them to be in the past, and I appreciate that's a bit tongue-in-cheek, to get them to the future, you've got to get them to the current first. I think you need revolutionary style actions there. So this means step changes in the way in which committees look at business cases. What is it acceptable to include in them? What the outcomes we're looking to be? What risk we're prepared to take, and where that risk is appropriate to the situation. But these are all big training activities, really. So that this is going to include the recruitment process in terms of bringing the right people in, as well as the ongoing training and staying up to date. We need to prioritize some of the back office teams in terms of training. You'll often hear the remarks that doctors and nurses are given a lot of their professional development time, quite rightly, but we sometimes neglect some of the back office services who are just as important in making these things work. So that's a big job that really isn't anything to do with equipment, but the downstream benefit is how we move into better equipment. If I say how we better acquire equipment rather than purchase, because the whole model is looking to move. And then in terms of the supply chain, they're more towards the model, and therefore I feel that there's more progressive type actions there in terms of if you can move your users to where you want them to be, the end providers will naturally start to build service and offerings that meet them, and we can see that because they've already done it with the current. So again, in my experience, people like Philips and GE are very open to change in the way in which they develop, in the way in which they progress, but they're doing it to a specific end result, which is their user interaction. So it starts with moving the users in a more revolutionary way, and then, in my view, the providers will naturally move in a more progressive way. There is a slight advert for DIV at the end here. I do apologise. Where do we sit in this? So we offer a current best of both approach, and that's largely because of our unique position as an owned subsidiary. So we have a lot of information, a lot of data in terms of use. So some of our service contracts do contain the level of risk that I'm talking about in a true service contract. We in a lot of cases very outcome based paid, and the subsidiary makes the investment with a lot of the assumptions in place, and therefore there's a quite significant amount of risk transfer, and that's obviously easy to do for us because of the detailed access to the data we've got. But there's a lesson there in terms of how we move forward in terms of third-party providers, because we don't make that data heavily available, or are poor at understanding it ourselves, and therefore if we can change that, then we could put OEMs into our position. Being closely aligned with the NHS trust needs or wider NHS needs, there's probably a trust element there in terms of all of our profit goes back in. So we have immediately avoid that private sector bad, public sector good kind of Orwellian approach that the NHS sometimes takes. And obviously that final point around the shareholder return, we don't really look at shareholder return in the same way. We look at benefit in the wider sense, and certainly our parent looks at the wider benefit we provide. So it gives us a bit of an advantage to almost trial this model. I think I've got one more after that. The future, yes, I did. If what I'm saying can be achieved, then really it removes the need for someone like DHive in the middle, because OEMs become the obvious partners to choose, because they have way better access into their own equipment. And again, I go back to my Rolls-Royce airline engine example. So what does this mean for DHive? In reality, if we get to where we have added value to our trust, then if it doesn't exist in the future, that's fine to some degree. We only exist to offer benefit into our parent. There will always be ways in which I think we can do that, and it goes back to the consultancy type services. We don't have the procurement skill set to meet the future I've described. We have a team of buyers who transact against frameworks, but never leave their office. And you guys will all be aware of procurement teams being out and about. So we struggle to attract the right resource from other sectors that can do this, and therefore I see an opportunity for effectively DHive to bring those skill sets in and offer that service to ensure the trust gets the right solution going forward, but not necessarily be a provider of that solution in the way we currently are. And how does that work on the OEM side? We're in the middle of some of this now, to be honest. So we're really well placed to demonstrate to the OEMs why these models would work, and be helpful in stimulating change within the trust, partly because of the owned nature of us, and therefore the more trusted nature. So some of the success we've had has been with working with third parties to engineer solutions into UHDB that we step away from once they're in, and it just becomes that consultancy piece in the middle, and explaining in detail with our skill sets to OEMs how best it can be delivered has been quite a valuable part of that process. The final part, and these are again things that are all on our future agenda, is essentially becoming an outsource provider to those OEMs for some aspects of the service. There's always going to be aspects of an NHS provided service that they don't want to really lose control of, and that goes back to the point I was making about our current managed service, where the end users really want the MES because it gets them what they want, but they really want the MES provider to go away once they've got what they want. That's all driven by this fear of losing control of certain aspects of the service, and that's where using your own subsidiary can sit into that space. So you retain that control through a different mechanism, and then it supports the OEM's core service without them having to get into a part of the service that they ordinarily wouldn't want to, or isn't core. So I think that's my last slide, and I have only really touched on some concepts there with a view to stimulating questions more than trying to cover everything that you might not be interested in. So I'm more than happy to answer questions that Mark pulls out of the chat later. But they're my thoughts on where we should be looking to head to.
Thank you, Darren. That's really enlightening, and I really appreciate you joining us today. The model you've got at DHive is quite unique, or pioneering. I think importantly, it's even pioneering, and already there are some questions coming up on the chat, which has come about from your presentation here. So I'll give you 5 minutes just to have a look at some of those questions, so you can have a chance to think about the answers for some of those, because it's either you or me that's answering it. So between us, we'll work through it. But just very quickly, because we're already running out of time, we've got a quick poll here, which we'd like everyone to take part in. So where is your organisation today in delivering or receiving as a service? If you could just quickly push the correct, yeah. Choose your preferred. Okay, so we've got exploring services, service exists but not core, scaling service-led models, managed service equipment, or advanced outcome-based. So this is just where are you in receiving or delivering as a service. Okay, so we'll close that in less than a minute. There are we nearly there?
Yep, I will get ready to close. Any last entries?
Right.
Okay, closing it now. Thank you.
Thank you. Very good. And as you can see here, yeah, exploring services is the strongest one there with 50%. And it's interesting because we do talk about Derby and Darren, you as a pioneering. As we can see there, service is still very in its exploratory stage, and I think that is definitely reflective of a lot of NHS trust. But also, I would go as far as to say, what is service? Because there's so many different interpretations of service, and yeah, you're smiling and I'm smiling because we know that, oh yeah, yeah, we get service, but what is that service? Anyway, we'll talk about that in a minute. Just very briefly, because I'd rather concentrate on the questions that we've got there. I was going to just go over, in the absence of Phil, go over about the value-based procurement. Some of you will be aware of it. It was released earlier in June, and it's basically to support the shift away, the focus away from lower upfront pricing. So this is where hospitals are purchasing at the best price, rather than looking at the overall value of that product, service, whatever it is, and what is best for the patient and the health system. So they created this value-based procurement guidance, and I hasten to say it's guidance, it's not mandatory, is it? So they don't have to use it, but I think Darren may have a take on that one, but I think it's going to be very important as we move forward in procuring equipment. So if we move on to the next slide, so the core principles of that value-based procurement is assesses a technology not simply on what it costs to buy, but how effective it is, and it's covering things like improves patient outcomes, enhances patient and staff experience, increase operational efficiency, supports sustainability and social value objectives, strengthens supply chain resilience, and reduces the total cost of care of the product's lifetime. And that's what we're looking at, is looking at a product lifetime rather than just an initial purchase of a product. And that reflects the NHS ambition to move from price-based procurement to outcome-based. So we're looking at what those products offer as an outcome rather than the price that it was sold to, and what that outcome can look like for the patient. So moving on, we have the value domains, the 5 value domains that it was split into. And you've got, it covers the social value. So that would cover things like environmental sustainability, carbon reduction, reduced packaging, responsible disposal of any equipment, and the modern slavery prevention. So it really does encompass the ESG philosophy of a lot of companies. Then we've got efficiencies. So we're looking at improvements in the productivity. So how is that going to improve the productivity, improve the patient throughput and care? Reduced procedural time, getting through more procedures, surgical procedures, and seeing more patients, and reduce length of stay, which is another critical aspect of it, and better use of resources. And we can talk about this in terms of managed service, because if you have somebody that isn't fundamentally a nurse or a clinician or something looking after the equipment, that frees them up to look after the patient. Then we look at the patient and the staff. We're looking at the values is based on the clinical outcomes, things like patient safety, patient experience, and staff well-being and usability of those products. So if it's easy to use, it's a much nicer environment. And I've seen that many times in operating theatres, where if equipment is complicated, it adds another level of stress. So actually being able to use it efficiently and effectively, and it's usable is a key ingredient to having a happy environment of staff. Supply chain, we're looking at supply chain resilience, security of supply, and business continuity. They're the three main areas of the supply chain value domain. And then lastly, the purpose. So how well the product meets the clinical and operational specification. How well does that product meet the clinical and operational specification that they require from it? So that's the key values. If we move on to the next slide very quickly, because I'm going to keep this down to a minute. One of the most significant elements of the guidance is about the weighting. So at least 60% of the evaluation should be based on the values domains, those that I just mentioned: social value, efficiency, patient and staff, and supply chain and purpose. At least 10% should be allocated to social value as in its own entity, and no more than 40% should be based on whole life cost, which is an interesting one there. But I think there's a lot of overlapping. So that 60% on the value domains, that does cover social values, and it also covers whole life costs as well. So not entirely sure how that mix is going to work in reality, because there's a lot of overlap in there, but it's moving towards the whole life cost and what the outcome is of that product, rather than the price as it used to be. The weighting used to be very much about price, and that was it. So as you can see, it's a deliberate attempt to prevent procurement decisions being driven primarily by price. So if you move on to the next slide, I've got details on this, but basically it means for medtech providers, we need to be looking at clinical evidence. It is no longer enough. We've got to be looking at the bigger, the outcomes, the productivity, the patient engagement, patient experience, and staff experience. Health economic data becomes critical. So suppliers need to increasingly provide evidence of whole pathway benefits. So how is that product going to benefit the pathway? How is it going to reduce the length of stay and avoiding complications? And then we've got things like we've got to look at procurement decisions that become more strategic, and implementation. So I'm having to rush through this because I know we've got a lot of questions. So these are the sort of things from a medtech provider we've got to consider now, rather than just price. If we can move on to the last slide, the next slide. So to summarize that, the NHS is increasingly looking at to buy outcomes, not products. Medtech companies can demonstrate, if we can demonstrate measurable clinical, operational, financial value across the patient pathway, we're more likely to be involved in those purchasing situations. And if companies can provide companies that provide service will be in a stronger position to address those clinical, operational, financial, because service encompasses all of those. in terms of the lifetime cost of the product. So if we move on to the next slide. So when we look at the NHS challenge, or one of them is doing more with less, they haven't got enough buildings, they haven't got enough staff, and they haven't got enough products. But if service can deliver improvements in the staffing, training, etc., and the products, then hopefully that will release finance to be able to get the buildings to put them in eventually. So that's a nice way of looking at it from a glass house, but ultimately that's what we want to try and achieve. So moving on, we've got 10 minutes just to cover some questions, and we've obviously got some great questions coming in, so thank you very much for those. Darren, do you want to, if I pick out, we've got time for a few questions. Darren, what is the time frame you think that these new business models will be fully implemented, perfect or not?
Yeah, so I've seen the questions. It's so I don't think there is a specific time frame for these. I think there'll always be an evolution from where we are now. There are some of these in place already to some degree. If I look at our core Storts managed service, for example, I think that's between what I'd call a managed service and a true service approach. Our imaging Agea managed service is, in my view, just an alternative way of procuring equipment, dressed up as a service with some risk transfer. And again, that's not a slight on Agea's offering. That was what UHDB asked for. So, but I know that the OEMs, certainly Philips and GE, we buy a lot of equipment from. I'm assuming Siemens the same, and Canon, for example. Of course, don't know so much about them. Are building out these models the same in a closer to a service point of view. So I think certainly within the next 5 years we'll see these models change. Some of that will be limited to existing contract cycles to some degree, and some of that's going to be heavily restricted around how technology is taken on board by NHS trusts, and how that alone changes the mindset of users. So a lot of trusts are going through updates to their patient record system, for example, and that's driving a lot of change in terms of how we look at technology and how we look at its use, how we use it, and how or whether we own it. So I think a lot of those seemingly unrelated things will play a part in how this kind of idea is adopted and how quickly that is. But certainly within the next 5 years, we're going to see more and more of these get closer to that true service model.
Yeah,
in my view.
Thanks, Darren. And I think the operational aspect of things like managed services is the thing that gives the most value, isn't it? In terms of, because like you say, there's different methods of procuring equipment over a longer period of time, but the operational value of that equipment and how it's looked after and how it's maintained, how people are trained on it, that's where the value is, isn't it? True value. Yeah. It's difficult to measure. Is it as a tangible value, but that's where the staff really appreciate support, because you're there operationally looking after the equipment, so they don't have to. They can support the patient, etc. But it's difficult to actually quantify, isn't it?
It is difficult. It kind of goes on to the other question, I think, around how the business case assumptions are made. Yeah. They are difficult to quantify, but the new regulations you've just gone through, or the guidance you've just gone through, I think is really interesting, because it's a really clever way, I think, of making finance a much bigger part of the equation, but forcing the end user to look at it in a very specific way. So all of those added value features, the word value gives it away to me. So the fact that procurement teams have been told they got to do that, I think, is horrific, if I'm being honest. And it was something I tried to instill in the team I had 5 or 6 years ago. they are difficult to value, but that's one of the things that NHS trusts are going to have to do. They're going to have to find a way of valuing in these benefits. If I was to give an example, one of the pillars that you put up was to do with staff and well-being effectively, and how they interact and experience. The sick rate for NHS staff is in UHDB is just over double the sick rate that I've got in my DIV team. And that alone, now there's a lot of reasons for that. A lot of those people work in areas where people are sick. Okay, so I understand there's always going to be a difference, but it shouldn't be more than double. So there's huge downstream benefits to going through a procurement process that considers the cost of people not being at work and being paid. And if the procurement model can start to put those factors in, as difficult as they are. So, and let's face it, a lot of things in the NHS are done because they're easy, not because they're right. So if we can find a way of doing those difficult things, then what they've actually done by putting this guidance out is made at least 60% based on value and at least 40% based on cost. Well, you've basically made a 100% model based on cost. If you look at it in the way a proper procurement person would look at it, they've just forced everyone to look at what cost truly is in the downstream, dare I say, trickle down sense.
Yeah, there's still a lot of questions, aren't there, with this value-based procurement and how it's gonna work, but the shift is the right way, definitely, and it's good that it's come out. We're running out of time, so I think what we will do is we will address these questions via email and share them with everybody that's attended here, because I know there probably will be some more questions as well that will come in, and we will look at these and email people back with answers from Darren or myself around to some of these questions. But lastly, for me, I want to say thank you, Darren, for coming on. It's been really great to talk with you. Really interesting presentation, and it's given us a lot of food for thought around service delivery and how that's going to fit in with the NHS. And with our project, and I want to thank everybody else for coming and joining us on this interesting journey that we're on. And if anybody wants to contact us, then please feel free. The details are there, and if you want to contact Darren, we can get through to Darren as well. So thank you once again, everybody. Thank you, Darren, and look forward to seeing you again in the future.
Thank you.
Thank you.